Welcome to Chapter 196, Evidence-Based Approach to the Treatment of Facial Pain. Here we will focus on trigeminal neuralgia, or TN, as it will be referred to for the remainder of the presentation. Evidence-based medicine has evolved significantly over the last 70 years, with an explosion of higher-tier, systematic reviews and meta-analyses more recently. This has led to increasingly better evidence in multiple areas of medicine, helping to formulate clinical guidelines and public health policy. The foundations of good evidence-based medicine are well-designed, unbiased research studies. While pharmacological treatments for TN have a robust evidence base in randomized controlled clinical trial methodology, in contrast, most of the evidence for the effectiveness of surgical treatments for TN come from observational studies. These studies do show that the currently available procedures are very effective and can produce complete post-operative pain relief for several years, even in pharmacologically refractory patients. Observational studies have been able to show this clearly because of the good effect sizes of these treatments. They have also been able to show the predictive value of severe neurovascular compression of symptomatic nerves identified on preoperative MRI scanning, indicating compression severe enough to induce changes in the volume of the nerve root or its displacement strongly predicts a longer remission after microvascular decompression than a more moderate or minor neurovascular conflict. However, microvascular decompression is less effective in patients with atypical TN, or have concomitant multiple sclerosis, or when the compression is caused by a vein, and repeated MVD usually provides no better outcome than less invasive percutaneous procedures. And we must remember that the risks associated with MVD, which can include hearing loss, brainstem infarction, and mortality, are marginally higher than with those other percutaneous procedures. To date, there are no randomized head-to-head comparative trials of surgery for classical or idiopathic TN. Although European guidelines examined outcomes after MVD and gamma knife surgery in 4 studies, and although all reported fewer recurrences of TN after MVD up to 4 years, all studies were low quality according to grade criteria. 2 further retrospective studies, given the grade rate of very low, suggested a more favourable outcome for MVD than balloon compression, radiofrequency lesioning, or glycerolysis. Due to a lack of studies, no preference can be offered for choice between neuroablative procedures for TN. It is not known how microvascular decompression compares with other procedures in relation to efficacy, tolerability, quality of life, and cost-effectiveness in patients with recurrent TN or MS-related TN, or in very old patients. There are numerous open questions amenable to controlled studies that can take advantage of the recent standardization of facial pain classification, pain assessment, and surgical approaches. For example, what is the preferred first-line intervention for atypical trigeminal neuralgia? What is the preferred first-line intervention for MS-related TN with MRI-confirmed vascular compression? And in more elderly patients, does MVD offer any advantage over ablative procedures? Certain problems specific to surgery are encountered with trial design. For example, adequate blinding, standardization of technique and operator influence, and equipoise, etc. The ideal collaboration is an international network formed to address some of these issues of experimental design in surgery. Along with describing a framework for development of stages in surgical innovation, it recommends how research at each of these stages can be optimized. Suggestions include modifications and alternatives to randomized controlled trial design that are appropriate for some surgical questions, for example, case matching studies, controlled interrupted time series, or step-wedge study designs. Trials can be costly and time-consuming. They can require multi-center or international collaborations to be adequately powered. In an effort to encourage greater engagement, groups such as the NeuroPoint Alliance have been developed by the American Association of Neurological Surgeons to collect, analyze, and report nationwide clinical data. This alliance also provides clinical trial management, study design, and survey facilitation. Taking this further, A cost-effective way to generate this kind of data is to embed data collection into routine clinical care. Although this requires considerable interconnectivity with data systems and buy-in from stakeholders, the benefits of generating data for effective clinical decision-making, as shown in large cancer treatment clinical databases, may be worth the effort. We will leave you with the key concepts and hope you enjoy reading the chapter. Thank you for listening.